performing gastric bypasses, we were from the beginning we were doing Roux-en-Y's, then comparing Roux-en-Y with mini gastric bypass, and currently 80% or 90% of gastric bypasses are mini gastric bypasses in our practice. I prefer this procedure because I am happy with the results, and it's much less complicated, much easier, and more effective than Roux-en-Y according to my results. The difference is that you have only one anastomosis in mini gastric bypass. Therefore, it is called also single anastomosis gastric bypass or one anastomosis gastric bypass. And it's more effective against diabetes and metabolic disorders.
Why would you choose it over a sleeve?
I prefer this because sleeves are, even though it is the most frequent surgery, but in the history we have seen that in periods of time when gastric banding was the most frequently performed and it's not the ideal procedure, we still do not have any ideal procedure, but in long term sleeves quite frequently, or maybe in 30%, have to be reoperated to gastric bypass for some gastroesophageal reflux or for weight regain, or most frequently for both together. Therefore, the mini gastric bypass or even the Roux-en-Y gastric bypass are more long-term sufficient methods, and therefore we decide for invasive and radical approach, I prefer the procedure which is forever effective. But it depends on you too, on your choice, and on the results of the examination.
Which patients are more likely to succeed with a mini gastric bypass?
With mini gastric bypass, we decide usually in those who are sweet eaters, who are more metabolic, suffer more metabolic disorders and diabetes. In those who have some already preoperatively some gastroesophageal reflux, it is still better, from my point of view, to do the bypass than the sleeve.